Non-invasive ventilations. This is our BiPAP and CPAP. What do we say the difference was between BiPAP and CPAP?
CPAP is continuous.
CPAP is continuous pressures. The alveoli stay open. BiPAP is like, yeah. Okay. How do you put it on? Y'all seen what a CPAP mask looks like, right? Yeah. People use this at home for like sleep apnea, things like that, right? Okay. And then BiPAP usually goes like over their nose, and you can do CPAP just over their nose too. Okay. Because you're basically just trying to like blow in their nose. Keep it open. Yeah. Okay. Because having it over their mouth all the time is really like you can't eat or anything like that. So they've created, y'all know what I'm talking about?
Yeah.
A little mask. Okay. All right. So CPAP is one continuous pressure, right?
Yes.
You have to be breathing on your own.
Yep.
Okay. So we would try this as the step to the next thing before we actually like ventilate the patient. However, you can add CPAP and BiPAP to ventilation.
Yes.
And do you understand when I say ventilation, that means they are intubated. There's a tube in their throat. It goes down to their lungs and it is ventilating the patient.
Yes.
Good. We didn't know that 5 minutes ago. Okay. So the job is to open the alveoli so that we can gas exchange, but you're basically like blowing in their nose and mouth, right? So that can cause trauma inside the lung, right? So we don't want to put the pressure too high, correct? Okay, because we don't want to like blow a lung or something. Okay. And then when you're increasing pressure in the lungs, that decreases your preload. How does it do that?
Not have enough room.
Oh, okay, that could be true. You don't have enough room. So it is, but it's not pushing the lungs open. Y'all understand that? Yes, it's only pushing the alveoli open. Now, when you're ventilated, that's pushing the whole lungs, but CPAP and BiPAP are just opening the alveoli, but it is changing the intrathoracic pressure. It's a different pressure, right? And so it's basically like forcing pressure inside, right? And so that can, just think of it like you have two separate systems, right? You have your heart system and then you have your lung system. So if you're putting more pressure on the lungs, the heart kind of is like because now you're pushing pressure in, which means it's pushing more blood, it's pushing more oxygen, which goes to the heart, right? But the heart can't really, like, it's working harder, right? But it's not, it may not be getting the blood flow that it needs. Okay. So the preload may decrease, but the workload of the heart is still like, oh my God, I have to work a little bit harder, which it probably was anyway. That's just a test question thing. Okay. So we usually use CPAP for OSA, which you already told me, and we'll use it for CHF. Why would we do that?
CHF, you have a lot of fluid retention.
You do have fluid retention, but why would I need to open my alveoli?
Because there's pressure on you.
In CHF, how much, okay, how much cardiac output do we have?
Not a lot.
Is that you? Okay. There's not a lot of cardiac output, so those patients can be hypoxic, right? Now, we can add oxygen for this patient, and we probably will, but will that be the most completely helpful thing? No. I'm going to have to actually force the oxygen in so I can force it into the alveoli and open it and turn it. Okay. Do you understand what I mean? Do you understand what I mean? Yeah. Okay. So complications of CPAP could be pneumothorax. What's a pneumothorax?
Like
a collapsed lung because what? There's
pressure.
Air
in
the pleural space, right? Which is right around the lungs. Because basically you can put CPAP so high that you blow a lung.
Yeah.
Oh no, we don't want to do that. Okay. All right. Do you understand CPAP and how it works? Okay. BiPAP, we said, is
Two different pressures.
Two different pressures. These are people that can't do two different pressures. So sometimes we use it for OSA. We really like to use it for COPD. How come? What are the two problems with COPD? As far as gas exchange goes, because that's what we're talking about today.
Diffusion.
So they get hypoxia and hypercapnia. So their oxygen is too low, their CO2 is too high. So how do I fix both of those at one time?
Different pressures.
You're going to change the pressure. You're going to push more pressure in so you can turn the water wheel. Do we understand? And we can fix both of those problems. Okay. Neuromuscular diseases. Why would I, like what? What am I talking about? Like what? Muscular dystrophy. Yeah, we could. I don't know, like ALS. Okay. So, you know, those kind of patients are going to end up on a vent, right? And since they can't really like take a deep breath, right? We're basically going to create the pressure for them. Does that make sense?
Yes.
Okay, so we would choose BiPAP if they're also having a hard time getting rid of their CO2. Yeah? Okay. All right. Helps to remove excess CO2, which that is the main problem with COPD, right? They can kind of live a little hypoxic, but they can't live acidotic. Do you understand?
Yes.
All right, so complications, lung injury, you can blow a lung. Yeah, or you can just cause a lot of pressure. Like if you think like if somebody is constantly blowing on you 24 hours a day, that don't feel good. Yeah.
Yeah.
Bloating, why would they have bloating?
Pressure.
Well, if they have this over their mouth and nose, right, or
over
this
their
over their
abdomen.
nose, some of it is going to go into the actual
abdomen.
stomach, and so it can make their stomach bloat. You got to be careful with that because they're at risk of. Okay, it's kind of the same way when you're doing CPR and you notice that the belly is rising instead of the chest. The air is going into the wrong place. If you got a shit ton of air in your stomach, I don't feel like this is a hard question.
It's going to explode.
No, it will not explode. It'll try to get out though by coming.
Aspiration.
Aspiration is your big risk because all. Are y'all okay? Okay. So all that air is going to try to come out, right? And they can aspirate. It's why when you're doing CPR, if you see their belly is rising, you better get ready because they're probably going to puke, even if they're like dead, right? You have to turn them to the side and then be like, oh, reposition the head, right?
Yes.
Okay, thank you. Wake up. All right, so we will use BiPAP with early ARDS. What is ARDS? Acute respiratory distress syndrome. It's basically just a very generic term to say your lungs done had it. Yeah. Beep, this is very bad. Okay. So we will always try non-invasive before invasive. We don't want to ventilate any of our patients because they have so many complications. Correct? Correct. All right. So when you are doing ventilation, it is very important to note whether your patient needs pressure or they need just like oxygen. There's pressure support and then there's like, I'm trying to get the oxygen in. Okay. This is pressure really only. These patients probably aren't hypoxic per se. Maybe some of them are, but really this is a pressure support. Does that make sense?
Yes.
For people that have like floppy alveoli or alveoli that don't work. Okie doke. Okay. What's a vapotherm? Oh, you'll see this a lot in the ICU. So, okay.
Like a humidifier?
Okay, so it is a high flow oxygen device. You can get a lot of oxygen at one time. Okay, flow rate of up to 40 liters a minute. That's a lot, right?
Yeah.
Right. But the oxygen is heated and humidified. So it makes your respiratory system much more accepting of it. Because I know when you put a nasal cannula on, it's dry.
Yeah.
And that can cause more like inflammation and pissed off a little bit. So these are for patients who need more volume of oxygen. Okay. So there's either pressure support or there's volume support. These patients need volume because we're giving them up to 40 liters. That's a lot of volume. Okay. So it's what we call a high velocity flow. It is thermally controlled. So it has its own heating system. Okay. 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 So you have a water bag that you will hang. Don't get this mixed up with your IV fluids. You're going to kill a man. We don't give straight water. Y'all know that. Yeah. Okay. So there's a water bag that is going to drip into the vapotherm device. Okay. It is going to create humidified O2 and that's what gets delivered to your patient. So if you needed more pressure, right, what are you going to use? CPAP or BiPAP. If you need more volume, vapotherm. Do you understand the difference?
Yeah.
Okay. So who needs volume? Who actually needs like air and oxygen? Those are people whose chest like will not expand right. Right. So those are patients that have had chest surgery or abdominal surgery. I know they won't breathe deep. Right. They're stitched or they're sutured together. And so you can't like, y'all know they're very restricted. Yeah. Okay. If they've had any kind of thoracic trauma, we haven't done burns yet, but like if you have chest burns, and it starts to, burns start to dry.
Yes.
And so they can't take a deep breath. Right. So I'm going to give them the volume that they need. Or if they have severe flu or pneumonia that are starting to go into ARDS because they can't really like, do you understand the difference between the two?
Yes.
All right.